Good day. Today we'll discuss articles on treatment, and this is my reference. Now, so we now talk of appraising validity of a treatment. Just to review you, we talked about last time. We talked about searching and acquiring the literature. And then when we search for the literature, we found a particular article. And so we said that we will be appraising the validity of that article. But in the appraisal of the validity of that article, we will first talk of appraising validity of treatment. Now, the validity of trials comparing two therapies almost depends entirely on how fair comparisons are between patients in the treatment and in the control groups. And there are criteria used for assessing the validity of therapy. And these criteria are phrased as questions. But before we go into these questions to assess the validity, the criteria for assessing the validity of therapy, let me just point out to you that in a clinical trial, and that's actually treatment, we will be comparing two treatment groups. And these two treatment groups, the two therapies that we are talking here, will have to be comparable in terms of characteristics. Because if they are not comparable in the characteristics, then there will be a problem in terms of the validity of the treatment. And so we go to the criteria that we will be using in appraising validity of treatment. And as we said, these criteria are phrased as questions. Now, a yes answer to a question means that the criterion is satisfied. There are actually 8 questions, criteria questions, and the more yes answers there are in the 8 questions, the more sure we become that comparisons are fair. So these are the 8 questions, and then we will discuss each of these questions one by one. So the first question, were patients randomly assigned to treatment groups? You see, class, let me just review to you what does random assignment means. We actually call this randomization. The allocation of treatment to patient groups have to be randomized, meaning the giving of treatment is at random. So we call this randomization, or simply random assignment of patients to treatment groups. That's actually the best technique to ensure the treatment groups are truly comparable. So how does randomization work? Let me just, as a matter of fact, this randomization technique, I already gave you this lecture to you when you were I think, in the second year, how randomization works. But let me just give you an example of how randomization is done. So suppose I want to have 2 treatment groups, one the experimental group and one the placebo group. So 2 treatments, one an experimental drug and the other one a placebo. With randomization, the simplest randomization that I can show to you is I have 2 ping pong balls, one color white and one color orange. So I put the 2 ping pong balls in a box, and then I shake the box, and then I get one. So the first patient that I will be giving, for example, the color of the ping pong ball that I get is white, and white will be represented by the placebo and orange by the experimental group. So first patient that comes to you will be given the placebo. And then I put the ping pong ball back to the box, and then I shake the box again. Then for the next patient, I get another ping pong ball. Suppose I get white. So the second patient gets as well a placebo. And then the next patient, I put the ping pong ball back into the box, and then I shake the box again. And then suppose what I get now is an orange. So the third patient will get the experimental drug. And then the next patient, I put the ping pong ball back. I put the ping pong ball back into the box, and then I shake the box, and then white again. So the patient gets the placebo, and so on and so forth until all patients have been randomized. You see, class, I intentionally said or used 3 ping pong balls and 1 orange ball in a sequence of 4 patients. But what I wanted to tell you is that, you see, there are more patients given the placebo than the experimental group in a group of 4 patients. Now, but when you get more patients, and when more patients, for example, number of patients now that I did the randomization is already 100, the number of people given the placebo and the number of people given the experimental drug will be more or less the same. You see, class, randomization ensures treatment groups are truly comparable, not only in the distribution of the treatment, placebo and the experimental drug, but to characteristics, known and unknown characteristics. So the treatment groups will have comparability as to the characteristics, as I said, known and unknown characteristics of people, of patients. Meaning, when you do randomization, the characteristics of the experimental group and the characteristics of people in the placebo group will turn out to be more or less the same, to be truly comparable. Because, as we said a while ago, the characteristics of these 2 groups of people will have to be the same, more or less, so that should there be a difference in the outcome, we attribute the difference to the drug. Because if patients are not assigned to treatment groups at random, then allocation may become unfair. Cases with poorer prognosis may end up being assigned to one treatment group. And so, one of the things that you will have to ask when you read the literature is that, where patients randomly assigned to the treatment groups, look for randomization as a method, as a design. If the design is a randomized controlled trial, and then you are able to answer this first question. Now, the next question is, was allocation concealed? You see, the random order by which patients are assigned to treatment groups is referred to as allocation sequence, the random order by which patients are assigned. Now, researchers must ensure that allocation sequence is not altered by clinicians who consciously or unconsciously tend to distort the balance. Meaning, clinicians might want that the next subject, the next patient, will get the experimental drug or the placebo. Now, when you do that, then the allocation of treatment for the next patients will not be concealed. Such measures are called concealment strategy, allocation concealment strategy. You see, it is important that the randomization scheme be unpredictable. That's why you need to conceal the allocation of treatment. Randomization scheme should be unpredictable, meaning which treatment group a participant will be randomized to cannot be predicted. And unpredictability is assured when the process of through the process of allocation concealment. Such scheme can prevent selection bias, meaning the potential for investigators to manipulate who gets what treatment. Now, the next question is, were baseline characteristics similar at the start of the trial? As we said, with proper randomization, baseline characteristics of treatment groups tend to be very similar. With randomization, they become similar. Now, there are, however, instances where dissimilarity in the characteristics between treatment groups may occur. And so, because as we said, this is a random allocation. So there may be instances that even though we have randomization, their characteristics tend not to be similar. But this occurs in very, very few instances. In majority of cases, characteristics should be similar if you do randomization. Now, should there be dissimilarity in the characteristics, you need to look for comparison in the baseline characteristics. So for you to be able to know if there are similar characteristics, look for comparison in the baseline characteristics between the treatment and then the control group. So from the results, you look into whether there is baseline characteristics. And if there are differences in the characteristics, and you will see the difference when the p-value is greater than 0.05. So that means that the characteristics, that particular characteristic is significantly different from one treatment group to another. Now, if there are differences, as I said, as shown by the p-value greater than 0.05, then check if they are adjusted in the analysis. Check if a multivariate analysis was done. Adjustment in the analysis means doing a multivariate analysis. Now, the next question is, were patients blinded to treatment assignment? You see, patients may respond to a treatment even if the treatment has no therapeutic value. That phenomenon is called the placebo effect. And that can happen more frequently for symptoms that are subjective in nature, like headache or body aches. Now, you need to blind the patients that they won't know what they are taking. But patients need to be informed that they can either be given a placebo or an experimental drug in 50% of the time, but they will not know what they will be taking. So, blinding does not mean that you don't inform the patient that they can be given the placebo. Patients still have to be informed that they can be given the placebo or the experimental drug in 50% of the time. So look, try to read this one in the paper if patients were blinded. Were physicians blinded to treatment assignment? When physicians are aware of the treatment group to which patients are assigned, they may treat patients in the two groups differently. For example, a clinician who knows his patient is on a placebo may worry and decide to take better care of that patient. Or conversely, a clinician who knows that the patient is on treatment may decide to monitor more frequently just in case there are side effects. And these changes in the care may make the treatment appear better or worse than it really is. So you need to look for this aspect as well, whether patients were blinded in the treatment assignment. And we need to look as well whether outcome assessors were blinded to the treatment assignment. You see, outcome assessors can be patient themselves or the caregivers, or the physician himself. But really, when you assess the patient as to their outcome, assessors need to be blinded. They must not know what the patients are receiving. For example, a patient may be asked if they feel better, or caregivers may be asked if they think their patients are doing well. So again, look for whether the assessors to the outcome were also blinded. Now, were all patients analyzed in groups to which they were originally randomized? What does this mean? You see, when there is randomization, so a patient will be assigned to the treatment group. Now, sometimes many patients, or some patients, I should say, in clinical trials may not complete the treatment protocol that they were assigned to, either because of intolerable side effects or loss to follow up, or even change the treatment assignment. So the patient, for example, the physician decided to change the treatment allocation. Now, a dilemma arises. Should all be analyzed in their original treatment group? We call this the intention to treat analysis. Or only those who completed the treatment, we call this the per protocol analysis. You see, what you need to look for is intention to treat analysis. If there is intention to treat analysis, then that's a good trial. But some trials do both intention to treat analysis and per protocol analysis. But of course, it's always best that you need to have this intention to treat analysis, because if the kind of treatment that was just done was per protocol analysis, meaning only those who completed the treatment protocol will be analyzed, then that's a problem. The reason for doing an intention to treat analysis is that when patients develop intolerable side effects and they are removed from the analysis, these side effects will not be reported. So you need to look for this specific word in the literature. Was intention to treat analysis done? Was follow-up rate adequate? Adequacy of follow-up refers to minimization of the number of patients who drop out from the study. The greater the number of patients lost to follow-up, the more the study validity is threatened. And the crucial issue is ascertaining when to worry about the number of dropouts. So we need to look for whether follow-up rate was adequate. Now, let me just show to you how to assess if there are just too many dropouts in the study. So we'll give you a hypothetical study, a hypothetical RCT, randomized controlled trial, where patients with severe pneumonia are randomized to receive either an active treatment, so 30 of them, or the placebo, 30 also, and there are 13 dropouts in the study, 6 on the treatment and 7 on the placebo group. Now, this is the first step. Count the number of dropouts in the treatment group. And the second step is count the number of patients with bad outcomes in each treatment group, and then express this as a fraction of the number of patients analyzed. So this is the first step. Count the number of dropouts in each treatment group. So in the treatment group, in the experimental, we have 6 dropouts, and then we have 7 dropouts in the placebo group. And then the next step is count the number of patients with bad outcomes. So deaths will be the outcome. So 5 divided by 24, expressed as a fraction of the number of patients analyzed. Since you only have 24, you analyze 5 over 24. You remove because this dropped out, and then in this one we have 9 deaths in the placebo, and then express this as 9 divided by 23 since 7 dropped out. So 23 remain. Now, step 3 is to create a worst scenario for the treatment group by assuming all dropouts in this group had bad outcomes and all dropouts in the control had good outcomes. Meaning, the worst scenario, you always create a worst scenario for the treatment group. Worst scenario for the treatment group, all who dropped out in the treatment group, all of them died. And the dropouts in the control, all of them didn't die. So that's step 3. Step 4 is just the opposite, creating the best scenario again for the treatment group. So when we talk of worst and best scenario, we always talk of the treatment group by assuming the opposite, meaning all dropouts in the treatment group had good outcomes and all dropouts in the control had bad outcomes. And so this is the table. This is the worst scenario. So we had, in the treatment group, we had 5 deaths and plus a dropout of 6, which we assumed to have died. We assume this is the worst scenario. All the dropouts had poor outcomes, bad outcomes, divided by 30. And in the placebo, we have 9 dropouts and all 7 dropouts survived, didn't die. So 9 plus 0 divided by 30, 27 plus 23 plus 7 divided by 30. That's the worst scenario for the treatment. And the best scenario for the treatment will be 5 died, and then those who dropped out didn't die. We assume them that they didn't die. And then for the placebo, all those who dropped out, all of them died, divided by, again, 30. So this is the best and the worst scenario. Now, calculate. So when we calculate, this is 36.7 for the treatment, and this is 30.0 for the placebo. Since many people in the worst scenario died, 36.7% of them died in the treatment and only 30% in the placebo. And then we say that the treatment is harmful. The treatment is harmful. Now, on the other hand, in the best scenario, we only have 16.7 who died in the treatment, but 53.3 in the placebo. Now, the next step, step 5, is looking into whether conclusions for the best and the worst scenarios are different. If they are different, then there were too many dropouts. Now, as just go back, so the conclusion in the worst scenario, treatment is harmful, but in the best scenario, treatment is beneficial. So they are different from each other. The best scenario showed fewer bad outcomes for the treatment, and that's benefit, while the worst scenario showed more bad outcomes for the treatment, and that's harm. And therefore, the conclusion is there were too many dropouts in this hypothetical study. Now, I actually have made a program in Excel where you will just input the values, and then you will see whether there are just too many dropouts or less dropouts. And I will show this to you later on when we meet again next week, just to show to you this formula. Now, exercise, if deaths on the treatment were 1, there is only 1 death in the treatment, and then deaths in the placebo were 16, would the same dropout rate still be worrisome? Now, I want you to calculate this one, so you might want to do this in your homes after this lecture, and then look into whether will the dropout still be worrisome. Actually, the answer is no. In the treatment group would have fewer deaths in both the best and the worst scenario. And again, we'll show this to you using the program that I made. I actually call it the dropout formula. Now, the 8 questions on the validity of the study have now been discussed. While it is tempting to be strict and insist that all 8 criteria be satisfied, meaning all 8 should have a yes answer, we must be pragmatic and remember that we sometimes need to make medical decisions based on less than perfect information. If you feel errors are small, or that this is probably the best study you will find that addresses your clinical question, then read the results. But if you feel errors are too great, meaning there are many no answers to the 8, and that there are better studies, then don't waste time reading that article. Now, what does errors are small mean? How many no answers must we have? 1, 2, or 3? There's really no hard and fast rule. But of the 8 questions, I give much weight, higher weight to some questions. For example, I give more weight to randomization, that there has to be randomization. So I give more weight to blinding. Patients have to be blinded, especially if the outcome is subjective. But if the outcome is objective, for example, one of the outcomes, is either death or survival, so that's objective. Or if the outcome, for example, is laboratory parameters, and that's objective, and then blinding may not really be blinding may not have really much weight. And then adjustment in the statistical analysis. There should be a multivariate analysis in the results, in the statistical test. So these are the things that I give much weight and of course the number of dropouts. These are the things that I give much weight. when I assess validity, when I assess these different questions, and then look into whether errors are small or just too great. Now, so we next appraise the results. And the questions that we will be asking are how large was the effect of the treatment, and then how precise was the estimate of the treatment effect. Now, the magnitude of treatment effect may be expressed by comparing outcomes in the treatment and in the control. And outcomes can be reported as quantitative. So, for example, blood pressure in millimeters mercury, cholesterol levels, reduction in weight, or it can also be qualitative, cured, not cured, dead or alive, with complication or without complication. For quantitative outcomes, the effect of the treatment is simply expressed as the mean difference. For qualitative outcomes, relative risk, absolute risk reduction, relative risk reduction, and number needed to treat have to be calculated or are calculated. Now, you look into whether the mean difference between the two treatment groups is clinically significant, because we can have a mean difference that's statistically significant but not really clinically significant. So we need to look into the clinical significance as well, because with a very large sample size, a mean difference that is small, that may not be clinically significant, can be seen statistically as statistically significant. So you need to look at the effect measure of the treatment. Now, we need to look as well at the number needed to treat. And the number needed to treat, the higher the number needed to treat, the poorer the drug is. The poorer the drug is. I hope just review what number needed to treat really means. Now, how precise was the estimate of the treatment effect? The interval estimate is another way of looking at the significance of the effect size. The interval estimate consists of two numbers, a lower limit and an upper limit, within which the parameter is expected to lie with certain degree of confidence. Conventionally, confidence interval are reported as 90, 95, or 99. But the 95% confidence interval is most commonly used. Now, when the 95% confidence interval excludes 1 in a relative risk or in the odds ratio, the effect of the treatment is statistically significant. If the 95% confidence interval does not include 1. Now, the next thing that you will have to assess is assessing applicability of the study. After evaluating the validity, analyzing the results of the trial, the next step is to decide if the results are applicable to our own patients. So you think that the article is valid, and you have analyzed the results, and you think that the results are good. So you now decide, will the results of this study be applicable to my own patients? For example, we can check, in assessing the applicability, we can check if our patients' characteristics satisfy the inclusion-exclusion criteria. So you need to look at the inclusion-exclusion criteria in the paper. Does my patient satisfy the inclusion-exclusion criteria? We can also look at treatment effects in the subgroups of patients that more closely approximate the individual patient we are trying to help. If there is a subgroup analysis, sometimes in papers, in some studies, they do have subgroup analysis. They might want to analyze only this particular group, for example, the elderly or people with comorbidity. So there is a subgroup analysis among people in this group. So, and then if the patient applies to the subgroup, so you look for the treatment effects in that particular group. Now, because data from subgroups are limited, healthcare providers must decide on applicability on trial results to individual patients based on the general information available to them. So, in many studies, we don't really have subgroup analysis. And if, for example, we can find a subgroup for my patient, and then you just base your information, just base your conclusion, your decision on the general information that's available. And for you to do this, biologic as well as socioeconomic status may be considered. Now, so let's talk first of biologic issues affecting applicability. Consider physiologic, hormonal, or biochemical differences between sexes that might affect the effectiveness of an intervention. For example, women have greater reduction in stroke incidence compared to men when treated with aspirin. So you need to look for this. Look at sex. What's the sex of my patient? Consider coexistent conditions that could affect applicability. Studies show that response to measles vaccination is reduced in malnourished children. So if your patient are malnourished, and then you might want to look into this if you are talking of a vaccination trial. Racial differences may affect applicability as well. For example, black hypertensive are more responsive to diuretics than whites. East Asians are more likely to develop adverse effects of cough from angiotensin-converting enzyme inhibitors, ACE inhibitors, compared to whites. So you look at the racial differences. Age differences commonly affect response to treatment as well. For example, flu vaccines lead to smaller reduction in the risk of influenza in older people. And then consider differences in the disease under study itself. So you need to look at the disease itself, because at times disease we refer to by the same name are actually conditions with slightly different pathology. And this can lead to significant variations in response to treatment. For example, malaria in Zimbabwe is different from malaria in the Philippines and is manifested as differences in the treatment response. So you need to look into these biologic issues as well when you look into applicability of the study to your own patient. Now, look at socio-economic issues as well that can affect applicability. Most trials are carried out under ideal conditions, which are difficult to apply in everyday life. So this is much a problem of provider compliance as it is a problem of patient compliance. Meaning, you can also have a provider compliance problem with provider compliance, the institution you are in, and as much there is also a problem of patient compliance. Now, patient compliance problems often relate to markers of socio-economic disadvantage like poverty or lack of education. That's patient compliance problems. So you need to look at that as well, socio-economic issues. Now, provider compliance, on the other hand, are often related to skill in the implementation of certain procedure or availability of necessary facilities in the institution where you are in. So you need to look at the provider compliance as well, because some therapies present both types of compliance problems. For example, warfarin administration for atrial fibrillation requires not only strict patient compliance with monitoring, but also availability of resources for pro-time determination and emergency management of life-threatening bleeds. So you need to this example will present to you with both patient compliance and uh, uh, patient compliance and provider compliance. Now, once satisfied that biologic and socio-economic factors will not compromise effectiveness, the next step and the last step actually is to individualize the benefit, risks, and cost to your patient. Because while studies report effectiveness of a treatment in a population as a whole, the benefits, risks, and costs will slightly differ from patient to patient. And the main source of this variation is the patient's baseline risk for the event that you're trying to prevent. So that ends my lecture on assessing validity of treatment of treatment questions on treatment or therapy questions. So we'll discuss this more when we have again a Zoom meeting next week for your questions and some issues or concerns. Thank you.